Good afternoon. Uh, our audience are coming back after a wonderful lunch. Morning we had wonderful sessions from our senior in sleep surgeons. So I'll be discussing about an important topic in a short time of 15 minutes. I have been allotted only 15 minutes for this extensive topic of drug-induced sleep endoscopy. Morning we have heard from Vijay Krishnan sir's presentation on what's the importance of DISE, especially in cases with where you have a revision surgery, and from Srinivas Kishore sir the pediatric DISE, etc. So I'll be covering DISE in a nutshell. Okay. So my first question is why do we need DISE? Okay, we all know that polysomnography gives the disease severity. It gives the desaturation index, but it never gives us it just hints which is the site of collapse, but it never gives us an idea about what is the exact site of collapse. You can do a CT or MRI also, which gives static obstruction, which will be helpful for your surgical planning, but again it won't give you the site of airway collapse. And awake endoscopy is mandatory when you are planning any kind of surgeries or any treatment. It should include a diagnostic nasal endoscopy and a flexible nasopharyngoscopy to assess the airway. But DISE is the ultimate in my terms because it helps you gives you a direct visualization of the dynamic airway. We all know that OSA is a dynamic pathology where the collapse is happening in the night during the sleep. So in DISE we are doing a nasal endoscopy when the patient is asleep. So this will give the dynamic, this will show the dynamic airway collapse happening. And imagine we discussed about this. Imagine two patients, patient A and patient B. They almost have the same polysomnographic findings, same AHI, same Epworth Sleepiness Scale scoring. But when you have done a nasal endoscopy in the OPD or a flexible scopy in the OPD, they have shown an identical findings. But think about this: if you are before the DISE era, you always used to do a UPPP or some kind of nasal surgery for all the patients. But after the introduction of DISE into the sleep surgeon's armamentarium, we are now able to do site-specific, patient-specific treatment. So both the patient has undergone a DISE, and the first patient it was a tongue-based fallback, and for the second patient it was a palatal collapse. Every patient is different, but polysomnography can be identical. So a DISE helps in differentiating these patients, and for the first patient we can go for a targeted tongue-based reduction surgery, and for the second patient a tongue-based surgery is not indicated. Even a hypoglossal nerve stimulation will also fail in case of second patient. So the DISE helps in picking up the right surgery for the right patient. So what is actually happening when the patient is awake? When the patient is awake, the muscle tone or the pharyngeal muscle tone is very good. The tongue tone will be there. The palate is intact, and the airway is mostly patent. But when the patient sleeps, all the muscle tone will be lost. The soft tissue, there will be collapse of the oropharyngeal tissues and the tongue, leading to sleep apneas. So as a sleep surgeon, we operate on a dynamic anatomy. So it should be always a dynamic evaluation which should help us which side to operate. So evolution of the DISE, it was in 1978 that Bogovic et al. First proposed natural sleep endoscopy, where an endoscopy was done when the patient was naturally asleep. But it needs a lot of resources, lot of time, lot of patience, etc. And only one patient can be endoscopied on a single day. Later in 1991, Croft and Pringle formalized the drug endoscopy, and there they given pharmacological measures and sedated the patient, and the same time they have done a endoscopy. In 2014, the Ward classification first announced. It standardized the reporting of a DISE. Okay, and in 2021, the first European paper came for standardizing the procedure, standardizing the scoring system, and taking care of the patients during the DISE procedure. Today, DISE is considered as an essential tool in the armamentarium of a sleep surgeon. And who all should undergo DISE? Any surgical candidate, anyone who is planning for a surgery, it's better to do a DISE on the day before doing a surgery. You can do it on the same day, or you can do it as a separate sitting and discuss the DISE findings with the patient, so that both of you can have an informed decision on the surgery and the success rates. Second is, any patient in whom you have a CPAP failure, we can do a DISE to identify what are the sites why the CPAP failed. There may be some conditions like epiglottic collapse or some sleep-induced laryngomalacia, etc., which can lead to CPAP intolerance in patients, and these patients can be picked up with a DISE. Failed prior surgery. Morning sir has had a wonderful session on surgery failures. So all patients who are going for a second surgery should have a DISE be done prior to the second surgery. In patients who are candidates for oral appliances, you can do a DISE, and same time you can do a mandibular advancement device titration with special gauges, which helps to predict the success of mandibular advancement devices. In patients in whom a positional OSA is suspected, here when you do a DISE, you can have an interventional procedure. You can turn the patient's head to one side or opposite side and see how the airway is improving. So this way you can predict the success of position therapy in DISE patients. Hypoglossal nerve stimulation candidates. If a patient is planning for a hypoglossal nerve stimulation, a DISE is mandatory prior to the implant, where if the patient has got a complete circumferential collapse, it is considered as a contraindication for hypoglossal nerve implant. And persistent pediatric OSA. DISE should be done in all patients who are Morning Sir has a wonderful discussion on the oration. He discussed pediatric OSA, pediatric DISE. So all persistent OSA patients should have DISE. And if your patients, suppose before taking for adenotonsillectomy, if the adenoids and tonsils are not matching with the size, clinical history or the patient symptoms, then do a DISE. In syndromic kids, Down syndrome, where you have hypotonia of the muscles, do a DISE prior to the adenotonsillectomy. Or in other craniofacial anomalies, there also you should consider upfront DISE rather than a second DISE after adenotonsillectomy, upfront DISE. So what are the essential setups you need for doing a DISE? The setup is generally like how you take a patient for a general anesthesia. Day before the 6 hours before the anesthesia procedure, we make the patient in NPO, nil per oral, and anxiolytics will be usually given, and the procedure should be done in a controlled setting where you have all the facilities to resuscitate the patient in case any airway collapse happens. So it should be done in a controlled setting environment, in a dim, the OT is usually dim lighted with less noise. Usually you 1 hour prior to the procedure, you give the patient something to reduce the secretions, which can be atropine or glycopyrrolate prior to the procedure. And before that, in adults, usually you spray with the 10% lignocaine when the patient is on the bed. It is usually will do it in supine position. And the infusions, and for the inducing the anesthesia, we will give propofol, and for continuing the sedation, we will use Desmed, or some people continuously use propofol also. It doesn't matter, because no drug has been so far proven it's safe. It's like 100% gold standard for DISE. And the other mandatory requirements are, you need a flexible nasopharyngeal laryngoscope. Ideally, the smallest scope is the best, smallest size scope. And you should have a suction channel, so that sometimes there may be a lot of secretions in the oropharynx which can be sucked out. A target control infusion system. This will help in maintaining a continuous flow of the IV sedation. This will be usually there in your theatre, because whenever you have a TIVA or total intravenous anesthesia, they are usually using this system. So you can use that, and this is recommended. And the most important is a BIS monitor, bispectral index monitor, which will help us know the depth of the sedation. Okay, the EEG waves we are picking, and based on that we know the depth of the sedation. And the most important thing is a brave anesthetist. Okay, you always form a team with a single anesthetist who is brave enough, so that when the airway collapse, he can take over it. And one more thing is, prior to all this procedure, you should have a PSG. Okay, that's one thing I missed. And step by step, where you select the patient, we review the symptoms, make the clinical diagnosis, and mandatory polysomnography should be done, so that we will be able to know what's the lowest saturation of this patient. Okay, till that level we can, when the patient is on the bed, we can go up to that depth of sedation. Patient selection. DISE should not be done if you don't have any plan of action. Okay, so do DISE if you have a surgical plan or a CPAP or some plan you have in mind. Drug administration usually use at target control infusion, and for sleep state use the BIS. The problem is that DISE usually takes around 50 to 20 minutes or 30 minutes maximum, but by that time you will be able to achieve only the N2 phase of the sleep, and all the medicines also they won't be able to reproduce the REM phase of the sleep. So this is the only limitation of DISE, where that you will be able to achieve only N2 phase. And the scope is introduced transnasally. The smallest size scope should be inserted, and the airway should be systematically inspected. First the site at the velum, second at the level of the oropharynx, third tonsil, tongue base, and fourth the epiglottis. In pediatric OSA, you have to carefully look at the nasal cavity, nasopharynx, and the laryngopharynx also. Sometimes same time we will do a bronchoscopy, tracheobronchoscopy also, so that there may be some secondary lesions, subglottic lesions or something we will be able to pick up. And the Ward classification, which is the commonly used system for scoring the DISE findings. There are other classifications also. NOHL classification is there, and Vikas Agarwal sir and Anand sir has come up with another scoring system for DISE. And treatment planning, based on all these findings you convert it into a meaningful treatment plan. So one thing to take care is the patient should be spontaneously breathing. A recommended BIS spectral value is between 50 to 70, and the observe at every station you wait for 2 events to happen and then score, and record if possible record a video and audio, so that later for your documentation and you can discuss with the patient also. So this is the Ward scoring system, where first level is at the level of the velum, and behind at the junction of the hard palate and soft palate you keep the scope and look for the collapse happening. Second of the soft palate. The soft palate, in Ward classification there can be 2 types of collapse for the velum. There can 3 types. One is antero-posterior collapse, second is circumferential collapse, third is lateral collapse. Again each collapse is divided into 2 types. One is complete, one is partial. If there is more than 70% of the vibration of the soft tissue happening, it is complete collapse. If it is less than 70%, it is partial collapse. So for soft palate you have 3 different, like that shown in that graph, that picture at the end. And second is at the level of the oropharyngeal level. You advance the scope little more deep and look at the lateral collapse. Mostly it's a lateral collapse that will happen with the tonsil tissue. And suppose if it's in a tonsillectomy, post tonsillectomy status patient, if you are seeing a complete lateral collapse, then that's a poor surgical candidate. And third is at the level of tongue base, where you look for the tongue base collapse. And fourth, whether at the epiglottis. The epiglottis has got 2 type of collapse. One is antero-posterior collapse, and second is it can collapse laterally also, like in laryngomalacia. So these findings, it has got a clinical relevance also. For example, if you are seeing a palatal collapse, it's an antero-posterior collapse. If you take the patient for, usually seen in young males and patients, if you have simple snoring patients, if you take for a cautery assisted palatal stiffening operation or something, or a simple anterior palatoplasty, you will have a good success rate of around 80%. And if you are seeing a complete concentric collapse, again like I said, these are poor candidates for hypoglossal nerve stimulation. Tongue base collapse, if you are seeing an epicollapse of the tongue base, this patient can be taken for a transoral reduction of the tongue base or a radio frequency ablation. Epiglottic collapse, you can take for epiglottopexy or epiglotectomy. And if you observe a multi-level, one limitation of DISE is DISE will pick up only 1 collapse at a time. You will be able to see only 1 collapse, but there may be multi-level collapses. At different times you will notice multi-level collapse. So based on the multi-level collapse also you can plan your surgery. Then a few words about interventional DISE. This is one advantage of doing a DISE, where you can predict the success rate of different treatment options. For example, chin lift. Some people will sleep with the mouth open. You just close the mouth, chin, and you will see immediately. You can see what's the response. So if a patient's tongue fall back get reduced by closing the mouth, you can give them a chin strap or just tape the mouth. That will help them resolving their symptoms. A jaw thrust. When the patient lies down, you advance the mandible. It's also called as Eschmark maneuver. You advance the mandible anteriorly. You will be able to see how much the advancement, the vallecula opens up, and this predict the success rate of mandibular advancement devices. Head turn to one side. You can turn to left or right and see what's the benefit of the positional therapy. CPAP titration, same time you can do a CPAP. You put the scope inside, give the DISE and see at what pressure the airway opens up, and this helps in diagnosing the pop and peak rate of the patient and helps in phenotyping the patients also. A MAD, mandibular advancement titration, you can when you put, there are special gauges which you can apply and advance it and see how much at what distance the tongue base fallback resolves. Nasopharyngeal airway, this is one of the most important thing, because there are two types of sleep surgery we are doing. One is single sitting, multi-stage, and multi-level, multi-stage, multi-level. So usually what some people are, some school of thought is that like, if you address the nose first and the second stage you can do later. So even if you put an nasopharyngeal airway, you can mimic the nasal surgeries and see the collapse. What's the collapse happening at the lower part? So if the nasopharyngeal airway resolves the lower airway collapse, a septal surgery will be helpful. So these are few cases. In the first, that's a normal DISE. Second one is an interventional DISE where you can see the tongue base when got lifted up, and the third one you can see the tongue epiglottis fall back. This is a normal patient. See, the weight was only 68 kg, BMI was 23, but his AHI was 35. His symptoms was only nocturnal choking. So you can see how the epiglottis collapse is happening. And this is post epiglotectomy and tongue base reduction. So a few words about pediatric DISE. These photographs are from the Srinivas Kishore sir's upcoming book on DISE, and usually we do indications of persistent OSA after adenotonsillectomy. Kids, like I discussed, kids with a hypotonia, craniofacial syndromes, suspected lingual tonsil hypertrophy, and when your clinical findings don't correlate with your symptoms. The impact means for identifying those kids who needs a lingual tonsillectomy, or those kids in whom you can plan an expansion pharyngoplasty. And so that said about, let's see what are the advantages and disadvantages. I have discussed all the advantages, like a dynamic assessment at multiple collapse. It helps in planning and individual patient-specific, site-specific treatment. It improves the preoperative counseling. You can show the records of the DISE and you discuss with the patient. It identifies the causes of treatment failures, identify unique causes of OSA like sleep-dependent and laryngomalacia. But one thing we will miss is REM predominant OSA, because through DISE we are not able to replicate the REM sleep. And it supports phenotyping of the targeted therapy, predict treatment outcomes. But what are the limitations? DISE is just a snapshot. It gives only a 15 minutes sleep, okay, that's all. But the normal sleep happens in 8 to 10 hours and short duration. Drug-induced sleep endoscopy is not natural sleep, and no REM representation. There may be inter-observability. 1V2 circumferential collapse may not appear as a circumferential collapse for a second person. And there may be scoring subjectivity. For one doctor it may be partial, and for the another one it may be a complete collapse. False result. If you sedate the patient more, there will be more collapse. If you less sedate, all the muscle tones will be there, so there may be less collapse. Cost, equipment and learning curve. It needs all these equipments for doing a theatre, and you need a good theatre backup. There was less standardized protocols and objective measures of DISE, and unwanted drug response. All the drugs we are using for DISE, they have some unwanted response, either in the airway or in the neuro CNS actions. And another thing is the mucus, excess mucus in the oropharyngeal airway, and the size of the scope which occupies the nasal airway. So always interpret the DISE results correlating with your PSG and clinical examination findings. So what are the alternatives? One is, due to lack of time, I'll quickly run. Second is sign MRI or drug-induced MRI, but the problem is that the lack of availability, and sometimes if something happens for the patient inside, when you induce the drug, give the sedation, and something happens within the MRI console, it will be difficult to resuscitate the patient. Other options are acoustic reflectometry, high resolution manometry, and apnea gap for device analytics. These are the other alternatives for DISE, or which can be used complementary with the DISE. And there are the newer technologies like AI induced scoring or automated VOT. AI is not going to replace a sleep surgeon, but this is where one sleep surgery is going to change. Like I said, right now there can be subjective variations, or AI is going to score the DISE findings, and it's going to be an objective based on how much percentage of the airway is collapsing, at what levels, and what type of collapse is happening. So it will become an objective scoring system. Then 3D reconstruction. An endoscopic view is always a two-dimensional image. You can combine it with the CD images or the MRI pictures of the patient and assess the airway volume and do the targeted resections. Computational flow dynamics, this is mainly a research oriented process because it needs a lot of engineering and computational support, and but right now it's only purely for research purpose. And quantitative DISE and robotic assistant. Quantitative DISE is what I told. Instead of partial or complete collapse, you are scoring the airway like 10%, 20% like that. 2 minutes. Scoring like that, and with the help of a robotic arm you can place the scope inside the oropharyngeal airway, and the surgeon's both hands are free for doing some maneuvers. The newer methods are digital twins, where the replica of the patient's digital replica of the patient's airway is created, and on that you can do computational airway dynamics and assess where the collapse is happening. So some practical tips: always avoid over sedation, use a BIS monitor whenever possible. Wait for stable breathing patterns before scoring. 2 events should happen prior to the scoring. Observe the multiple respiratory cycle, and don't panic when the SpO2 falls. Whether you or your anesthetist should not panic, because look at the hypnogram, see what's the lowest saturation of that patient. If it's about 60, 65, that patient is going through that hypoxia daily. So even when you see your saturations falling on the monitor, don't get upset. And documentation. Record every case. Always perform interventional maneuvers when you are doing a DISE. Correlate with the PSG findings. And be careful when you do a pediatric DISE, because kids saturation fall can happen fast. So the take home message is DISE complements PSG. It is never a replacement for your PSG. Prior to doing a DISE, you should have your PSG. Proper sedation with the target controlled infusion and with an BIS monitor is mandatory. Currently what remains the central score for scoring the DISE system, and interventional DISE, if you do, you can change your surgical plans. Video documentation should be standardized. Thank you. If you have any questions.
At what BIS level you keep the patient sleep? When you monitor with this BIS monitor, what is the score at which you keep?
50 to 70, sir.
50. Okay, nice presentation, Sanu.
Thank you, sir.
Thank you, doctor.